Hey guys, Nurse Mike here from SimpleNursing.com. Today we're breaking down ventilator settings made easy, covering AC, SIMV, FiO2, and all the big concepts that you need to know for your exams and clinicals. We'll make it simple, relatable, and memory packed to make sure it sticks. And if you're a Simple Nursing member, be sure to grab these two study guides to follow along. All right, take a deep breath. See what I did there? And let's get started.
Mechanical ventilation means that a machine is mechanically giving breaths or ventilations to a patient. And the ventilator is the actual machine that works a lot like an air pump that pumps air into tires on a bicycle. In the same way, we're pumping air into the lungs. This is called PPV, positive pressure ventilation, which is very different than normal breathing. You see, in normal breathing, the diaphragm and lungs use negative pressure to bring in oxygen, rather than having it blasted from positive pressure being pushed into the lungs. Naturally, this PPV, or positive pressure, is a big danger. It can cause trauma in the lungs with overinflation. This trauma is called barotrauma. So just think breathing trauma for barotrauma, that damage to the lungs. And in severe cases, it can even pop a lung if the pressure is high enough. This is called a pneumothorax, or a pneumothorax as I like to call it, for a popped lung. But we'll cover this in the complications segment, and also all the ventilator settings, like alarms, monitoring, modes, and settings. But first, let's cover the most tested topics for your NCLEX and exams. First up is suction, which causes a huge risk for trauma, bleeding, and hypoxia, that low oxygen. So it's only performed when needed. Now the top 5 key points that are most tested, write these down. Number 1, we always suction out, never in. Key terms is never apply suction when inserting the catheter into the airway. So the memory trick, just think, to get secretions out, we suction on the way out. Now, number 2 is 10 seconds or less for suctioning. And number 3, 100% oxygen 30 seconds before suctioning, since suctioning can remove oxygen and secretions at the same time, which causes a huge risk for hypoxemia and even cardiac dysrhythmias. Now, number 4, we avoid suctioning before ABG draws. Huge NCLEX tip here. We have to wait at least 20 minutes since it will deplete oxygen levels and show incorrect results. And number 5, avoid suctioning routinely. Huge risk for trauma. Key term here is acute lung injury. So we only suction when needed. So watch out for the key term routinely. Don't get tricked here. Avoid suctioning routinely. Many students get this wrong. Now a little side note here. Kaplan mentions we adjust the FiO2 when preparing to suction the endotracheal tube. And Hesse mentions a patient with increased ICP, when should suctioning be performed? When the O2 sat drops because of increased respiratory secretions. The key term here states that increased respiratory secretions indicates an assessment has been made. So before the intervention is done, don't get tricked. Always assess before suctioning. Next is oral care, and the big key term here is VAP, ventilator-associated pneumonia, that deadly infection inside the lungs. We have to do 2 key things here, so write this down. Reposition side to side every 2 hours to help mobilize secretions. And number 2, oral care with key term chlorhexidine every 2 hours, typically followed by oral suctioning. So a common exam question here is the best indicators of ventilator-associated pneumonia, that VAP. Select all that apply. So the best indicator for that VAP is a positive sputum culture, a fever over 100.3, and even chest x-rays that show new infiltrates. And a common NCLEX question here is appropriate interventions for a patient intubated on continuous sedation to prevent that VAP, ventilator-associated pneumonia. Select all that apply. So, daily sedation and weaning protocols, called sedation vacations, Number 2 is elevate the head of the bed at least 30 to 45 degrees. Number 3 is that oral care with chlorhexidine. And number 4, as usual, hand hygiene. Always wash those hands. And number 5, no, that is incorrect. If you chose that, then you nasty.
If you want more tips and tricks for questions like the ones we just walked through, our Simple Nursing membership has exit prep lectures and thousands of questions on every nursing school and NCLEX topic, written by current professors and NCLEX writers.
Next is NG tube feeding and GI ulcers when a patient is intubated. So, starting with NG tube, write this down. No bolus feedings due to the increased risk for aspiration. So let's be real here. A bolus feeding is like taking a beer bong. That's a lot going in all at once. Huge risk for choking and aspiration. So we always use continuous feedings to prevent that aspiration when a client is on an ET tube. Number 2 is GI stress ulcers from gastric secretions that burn a hole in the GI tract. So ATI mentions a complication associated with long-term mechanical ventilation is stress ulcers. So we typically give acid reducers like PPIs or H2 blockers prophylactically to prevent those ulcers. Next is complications, and the number one thing is a dropping O2 saturation. You must always assess first. So write this down. Auscultate lung sounds. So again, always assess before any intervention to confirm tube placement. If secretions or a mucus plug are the problem, then we simply suction it out. But if it's not, and the O2 sat keeps on dropping, then we must use mechanical ventilation with oxygen attached and call for help. Now, don't let the NCLEX trick you here. We do not give high flow O2 via non-rebreather mask, since it doesn't provide ventilation or breaths into the lungs. Now, number 2, as mentioned before, is secretions. Then we simply suction it out. And number 3 is that manual ventilation with a resuscitation bag or an ambu bag. So naturally, bedside essentials, we have to have an extra intubation setup and that bag valve mask or ambu bag, also called a resuscitation bag. So Kaplan mentions essential to have resuscitation bag at a bedside when a patient is intubated. Now, other complications, as mentioned before, is a pneumothorax or that popped lung from barotrauma caused by that high PEEP. Huge NCLEX tip here. So write down these key terms. Over 60% of students miss this. So remember, the pneumothorax is a popped lung from too much positive pressure from that vent, aka PEEP, which ruptures the little alveoli in the lungs, and now air trapping is inside the pleural space. And lastly, number 3 is our hypotension, that low blood pressure. Another adverse effect from all that positive pressure going into the lungs, causing pressure on the thoracic blood vessels. Sort of like squeezing the heart down, reducing the heart's ability to pump, which reduces cardiac output. So less blood being pumped out of the heart for less cardiac output. And this causes blood pressure to drop. Lastly is extubation. So when a tube is taken out, we have a high risk for airway obstruction and respiratory distress. So write this down. We always use warm, humidified oxygen via face mask. Number 2 is oral care with, key term here, oral sponges. So no ice chips and no oral fluids. We have a high risk for aspiration and airway obstruction. Number 3 is the NPO, so nothing per oral. And lastly, number 4 is high Fowler's position. So make sure the head of the bed is up to maximize lung expansion and prevent aspiration. Now, 2 deadly risks after extubation. First up is atelectasis and pneumonia. So atelectasis is where the alveoli collapses and traps infection, leading to deadly pneumonia. So we must instruct the patient to use the incentive spirometer every hour in order to re-expand and open up those weak alveoli. And number 2 is turn, cough, and deep breathe to mobilize secretions and cough out all that mucus which causes the infection. Now, number 2 is the stridor here. We call it the stridor squeak. It's a noise heard upon inspiration, indicating a very narrow airway. This must be reported immediately because it's a huge airway issue and a medical emergency. So ATI mentions a stridor following extubation, we must report to the provider immediately. And Kaplan mentions, extubated from endotracheal intubation 10 minutes prior. The priority assessment finding to report to the HCP is the stridor. So just think, a stridor squeak is very serious. You must report this. Now, a bonus side note here is tracheostomy care. The number one priority for a new tracheostomy. We're talking immediately after surgery, fresh postoperative. We must, key terms here, check the tightness of the ties and use one finger to fit under the ties. This prevents dislodgement and loss of the airway. So write that down. The number one priority for a new tracheostomy, returning from the operating room. Now, the NCLEX focuses on things that will kill the patient and other safety topics primarily. So always focus on things that will kill the patient or cause harm. The worst thing that can happen is accidental dislodgement of this tube, resulting in that loss of airway. Since the new trach placement is very difficult to reinsert because it takes time to heal. So we must check tightness of the ties to prevent that lost airway. That's always the number one priority. So don't let the NCLEX trick you here. Priority is always airway. Not performing mouth care to prevent infection, and not doing a dressing change on this new trach or changing the inner cannula. Many students get this wrong. So please write it down. Checking tightness of the ties means maintaining the airway here. Okay, now what happens if the tracheostomy does get dislodged or pops out? Let's say you're going to check on your patient and you find the trach tube sitting on the bed. Oh, snap! Well, now we have a loss of airway from a closed stoma, and the patient's gasping for air. This, my friends, is a medical emergency. So what's your first action? Well, we need to secure that airway, right? So listen close here. For a mature tracheostomy, 7 days or more, we insert the new tracheostomy tube using a curved hemostat. But technically, we should always have an arbitrator at the bedside used to reinsert. And number 2 is we cover the stoma with a sterile occlusive dressing and ventilate the lungs by using a bag valve mask over the nose and mouth. Now, those 2 steps love to show up on the NCLEX, since this is a life-saving intervention here. Now, let's just say it's a new tracheostomy, less than 7 days. Well, then we only do number 2 here, covering the stoma with that occlusive dressing and then using a bag valve mask to ventilate the nose and mouth, since the trach is not mature enough to be immediately reinserted. Lastly, a little side note for other key points. Kaplan mentions controlled mandatory ventilation for clients with Guillain-Barrés, which I call ground-up berets, since ascending paralysis goes from the feet to the respiratory tract and paralyzes the diaphragm, which we cover in another video. But since it's very deadly, it's highly tested here. And Hesse mentions a patient with increased ICP has normal pH, increased PaCO2, that carbon dioxide. The HCP orders an increase in respiratory rate of the patient's ventilator. The nurse knows that this change should have which outcome on the patient's ICP? Well, it will decrease the carbon dioxide, which will decrease that ICP via vasoconstriction. You see, carbon dioxide dilates the blood vessels, making the blood acidotic. We call it carbon diacid. And this dilation from carbon dioxide allows way more blood flow to the brain, which increases ICP, that intracranial pressure. So we need to get all that acid out of the body by blowing it off with hyperventilation. Like, get your acid out of here. So hyperventilation puts the patient into respiratory alkalosis. So think of panting like a dog for alkalosis. So without carbon dioxide making the blood acidic, we vasoconstrict the blood vessels for less blood flow and less pressure to the brain. Now, switching gears here, let's cover all the key ventilator numbers, from alarms, modes, settings, and monitoring. First thing I want to highlight is the pretty blue light here. This tells us a lot of important numbers. Then down here at the bottom is the clear, curly stuff, which a lot of lung butter builds up in there. Lastly is the big old round dial here, always a family favorite. Oh yeah, you turn this sometimes and I'm just kidding. This is actually a meme from Facebook, and I think it's pretty funny here because half the time no one knows how a ventilator works. They just push it around like a big refrigerator. Okay, let's start the lecture starting with alarms. So we have two types, low pressure and high pressure here. So for low pressure, this is known as a low tidal volume alarm. Just think of the double L's here. It means L, we have a loss of connection resulting in an air leak. Now, it's typically caused from a cuff leak that's not tight enough, or ET tube displacement, which is very scary, or just disconnection of the tubes. And high pressure alarm, also called high peaked pressure alarm, just think H for high blockage. Anything that can cause a blockage of airflow resulting in peaked airway pressure. So we must assess first for blockage. Now this is typically from biting a tube, kinks in the tube, excessive airway secretions like a mucus plug, or even coughing, which is probably the most common. And another common one is a client who fights the ventilator, typically when waking up from sedation. Now, some more serious ones are pulmonary edema, that fluid in the lungs, and pneumothorax, that popped lung with trapped air. This causes more pressure. So really, just anything that causes a blockage of airflow. Now, Kaplan mentions a client with emphysema receiving mechanical ventilation appears restless and agitated. Priority action when a high pressure alarm sounds. Instruct the client to allow the machine to breathe for the client. And a common NCLEX question here. The nurse responding to a high pressure alarm on the ventilator would assess for which condition. So once again, think high pressure, high blockage. So option number 1, auscultate the lungs for pulmonary edema. Yes, this is high blockage. Option 2, biting the ET tube. Yes, again, another blockage. Now option 3 and 4 are incorrect. Tube displacement, guys, that's a low leak here, a leaky air. And number 4, disconnection of tubes. Again, we're leaking air. There's no blockage here. And option 5 and 6 are correct. Excessive airway secretions can cause blockages, and kinked airway tubing will definitely cause a blockage. Now let's cover modes here. The two ones you have to know is AC and SIMV. So AC is for assist control. This means full machine control over the patient's respiratory rate. So it's 100% machine control, typically used after CPR or even in life support, like long-term care clients. So just think AC is for actively controls breathing. Next is SIMV. This is known as the weaning mode. So the fancy word is synchronized intermittent mandatory ventilation. Basically, the patient controls breathing mainly, and the machine assists. So think of the double S's here. S for SIMV is S for step down. We're basically stepping away from full control, and we're doing the weaning. We're allowing the patient to take control of their own respirations here. Next is all the main crazy settings here. So starting with the first one, VT, also known as V4. This is known as tidal volume. Now, I know you're probably thinking it should be TV, but no, it's VT. So the description is the volume of air set to be delivered with each breath. So every time a patient takes a breath of air, this is the volume they get. So 500 to 800 mLs of air is typically normal in terms of how much air they get. So the memory trick for tidal volume Just think a tidal wave of air. Next is FRR. This is our frequency of respirations. So just the number of breaths per minute. And just like normal, like your normal vital signs, 12 to 20 is the typical setting here. So the memory trick, just think FRR as freaking respiratory rate, man. Okay, next is FiO2. It's our oxygen concentration, typically between 35 to 100%. So naturally, higher the oxygen percentage, the more severe the patient is. So the memory trick, FiO2, just think FiO2 for feed me O2. Next up is our PEEP, positive and expiratory pressure. So I would really focus on this one because a lot of complications, really the most deadly complications, come from this setting. So it keeps the alveoli open with positive pressure at the end of the respiration. And a huge caution is that barotrauma, which eventually can even lead to a popped lung, that pneumothorax. So the key point is the PEEP improves gas exchange, keeping that alveoli open to push oxygen in and expel CO2 out, especially with ARDS, where fluid fills up that alveoli, which blocks gas exchange. So for the memory trick, think of the double P's. PEEP pushes open that alveoli. And very lastly is the PS, kind of like when you're writing an email and you leave PS. This is our pressure support. It pushes air to help with spontaneous breathing. So think PS is spontaneous breath support, just helping the patient breathe when they want to take a spontaneous breath. So a common NCLEX question always revolves around the most deadly complications here. So which complication is associated with excessively high levels of PEEP? And the answer is barotrauma, or even pneumothorax. Remember, a popped lung from too much pressure being pushed into the lungs, or basically this positive pressure from the vent being pushed into the lungs. That's the worst case scenario. Okay, next up is monitoring. We have three types: the VE, the PIP, and the PIMP. I'm just kidding. And the Pplat. So first up is the VE. This is for minute ventilation here. It's the amount of air delivered per minute. So the memory trick is VE, ventilations every minute. Next is our PIP here. So peaked inspiratory pressure. This is the max pressure during inspiration. So the memory trick, think PIP is the tip of max pressure. And our last one here is Pplat, our plateau pressure. This is pressure applied to hold open the small airways and alveoli before expiration. It indicates lung compliance. For example, our patients in ARDS who have stiff, hard lungs, the lungs are not compliant, they're stiff and hard. So plateau pressure gently reopens the alveoli by holding it open a little bit longer. So the memory trick, think plateau is a paused lung to hold open the air sacs just a little bit longer.
Thanks for watching. Did you know you can unlock beautifully handcrafted study guides packed with key points and memory tricks from all our videos? Plus, you'll get access to over 1,200 exclusive videos not on YouTube, all neatly organized by nursing school topic, to make that complex nursing knowledge actually stick. You'll also gain thousands of practice questions written by current professors and actual NCLEX writers. So for access to all this and more, click right up here or visit simplenursing.com. And don't forget to subscribe to our YouTube channel. Happy studying, and we'll see you in the next videos.